Hello, welcome to ecancer discussions. I'm Christos Markopoulos. I'm breast oncoplastic surgeon, professor of surgery in Athens University Medical School. And I have the pleasure to discuss the RxPONDER trial and its impact on best clinical practice with Professor Giuseppe Curigliano, medical oncologist and head of the division of early drug development at the European Institute of Milan. Hello, Giuseppe.
Thanks a lot, Professor Markopoulos, for your introduction.
So if we go back, allow me to remind you that for the last 10 to 15 years, multi-gene assays are helping us to have our treatment decisions more personalized and more precise. Oncotype DX was the first commercially available assay for ER-positive, HER2 negative women, and it was validated retrospectively in patients from prospective randomized trials from very well-known worldwide groups, NSABP and SWOG. And in all these trials proved to be prognostic and predictive of chemotherapy benefit. Most of all, we had the first two large prospective randomized trials, Taylor-X trial for lymph node negative, and now the RxPONDER trial for lymph node positive patients. And Giuseppe, I think you would agree that not all lymph node positive patients need chemotherapy. So this is what was missing, wasn't it?
Yes, absolutely. I agree with you. The RxPONDER trial was finally a prospective randomized trial, including patients with the ER-positive, PGR-positive disease, HER2 negative, with 1 to 3 lymph nodes involved and able to receive an adjuvant chemotherapy. Patients with a recurrence score between 0 and 25 have been randomized to receive chemotherapy followed by endocrine therapy or endocrine therapy alone. And the major question was whether we need to give chemotherapy to all patients with node-positive disease and a recurrence score between 0 and 25. As you know very well, in the primary analysis, women postmenopause between 0 and 25 with 1 to 3 lymph nodes achieved no benefit from chemotherapy. So this was an important information because in the past, we gave a lot of chemotherapy to those women. But in the analysis, in the primary analysis published a few months ago, there was a clear benefit from chemotherapy in premenopausal women with 1 to 3 lymph nodes and with a recurrence score between 0 and 25. In this updated analysis that has been presented during the San Antonio meeting, the question was whether ovarian function suppression alone in premenopausal women can be predictive of a benefit. But looking at a landmark analysis that has been performed usually after 2 years in order to understand, of course, if the suspension of the menses can be really the window to understand if there was an effective of a medical suppression of the ovarian function, demonstrated that there was no invasive disease-free survival difference in premenopausal women if ovarian function suppression or not in the first 24 months assigned to endocrine therapy. So this was surprising for us because finally it seems that the benefit was still related to chemotherapy. So a numerical improved invasion disease-free survival benefit in premenopausal women was observed finally in the arm that received chemotherapy. Of course, very few patients received an adequate ovarian function suppression in the RxPONDER. But in the final analysis, if we look to the clear data, premenopausal women with 0 to 25 recurrence score had benefit from the addition of chemotherapy to endocrine therapy, with a 44–46% reduction in the invasive disease survival, distant disease-free survival, and in the exploratory analysis also PN1 micrometastatic disease, there was a still benefit from chemotherapy, even if a limited number of events. So this is still an open question. Yes.
Right. However, we have to be cautious about all this. The first thing I would like to mention is that ovarian function suppression was used in a very small number of patients, and therefore we can't have definite answers to that. Not forgetting the data we have from soft and text trials. And also in regards to my field of surgery, the lymph node micrometastasis was only found in a very small number of patients, 206 patients, meaning again, I could say we don't know. And we can only say that there is a trend that might be the case, that also patients with micrometastasis have some benefit on that. However, talking about no benefit of chemotherapy in premenopausal women, I would like to notice that we shouldn't forget that in the multivariate analysis, Oncotype DX, the recurrence score, proved to be again a strong prognostic factor, independently of the other findings, as well as the tumor side. So having all these clear results now, I think it would be very important in clinical practice to discuss two things: how our life, our patient's life will change from these results, and because it is clear that postmenopausal women will take the highest benefit of these results. Don't forget that most of our patients are postmenopausal, over the age of 50. Most of breast cancers are ER positive, HER2 negative. So if we put together the two trials, TAILOR-X and RxPONDER, we all understand that in clinical practice, thousands of patients will safely omit chemotherapy without any detrimental effect in IDFS. So the question is, what are we going to do with the premenopausal women? Is there any room of ordering Oncotype DX in premenopausal women with 1 or 2 lymph node positive, for example?
This is a very provocative question. You clearly stated that in postmenopausal women, we have a huge benefit from using Oncotype DX. But RxPONDER was not powered for subgroup differences. And data interpretation in premenopausal patients is, of course, challenging. As you said, we don't know clearly how many of them received ovarian function suppression. We don't know exactly when they became postmenopausal. And also the number of patients with micrometastatic disease was very limited. So it remains unclear if ovarian function suppression can replace chemotherapy in premenopausal women, node-positive breast cancer. And only a future trial that should be randomized should be considered to address this important clinical question. One thing that we can do is to analyze according to Oncotype DX soft and text. This can be a proposal, of course. And the second thing maybe is to re-challenge again the PERCHE trial that you decided and you designed with other investigator many years ago, and that has been never completed. It was a trial exploring in premenopausal women chemotherapy plus ovarian function suppression versus chemotherapy versus endocrine therapy alone. So should I use in premenopausal? I believe yes, because not all women premenopausal should receive chemotherapy. I am still sure that some women with clinical pathological features that are favorable and with the low risk according to recurrence score can be still treated with endocrine therapy alone. And as you stated perfectly, softened text seems to demonstrate this.
So we would agree that even for premenopausal patient, we could analyze the tumor with Oncotype DX. And in my mind comes two situations. For example, if we have a premenopausal but over 50 women, or if we where if we see the results of RxPONDER, there is still benefit of chemotherapy, but it's less. So we could probably, depending on our discussion with the patients always, because I believe as I do, you do also discuss all these results with the patients for the final decision. In this case, we could go to hormonal therapy with ovarian suppression. And another case, it comes to my mind, it could be probably a younger woman at her 40s, not at her 30s, because there I'm sure that you should give chemotherapy with a very low recurrence score, meaning good prognosis. And if we also see the two groups in RxPONDER trial, the first group up to 13 recurrence score had certainly a benefit from chemotherapy, but this was much less compared to the second group, even though there was no statistical significance. So probably in a woman with a very low recurrence score, we could personalize her treatment by discussing the advantages and disadvantages of giving her chemotherapy. And also coming back again to postmenopausal women, I was thinking I would like to ask you if you think that there is any room in having in a locally advanced postmenopausal breast cancer, certainly with lymph node positive, a recurrence score in order to decide about primary systemic treatment, endocrine or chemotherapy. Would you do that?
Yes, absolutely. I believe we have some clinical trials ongoing in which there is, of course, the use of Oncotype DX to select those patients who should receive chemotherapy. I did in my practice, even if there is no evidence from clinical studies, and every time I used it, it has been very useful. So I believe in the future there will be a major role also in the neoadjuvant setting to select those patients with ER-positive HER2-negative disease post-menopausal that can be candidate to neoadjuvant treatment. So you raised a very, very good point.
Mm-hmm. So summarizing all this, we should, or before summarizing, we should also mention that all this change is in favor of saving our patients from side effects, and also the cost from NHS. The workload can be limited and save resources, especially now times. We need doctors to deal with a lot of other things and save cost by safely omitting chemotherapy. Wouldn't you agree that it's a huge change in the system?
Absolutely. We will save a lot of money from chemotherapy and also from side effects induced by chemotherapy, and the quality of life of the patients will improve dramatically. I completely agree with you.
I think that they are planning also a quality of life analysis in RxPONDER, which will be very interesting. So summarizing the data, the results we have from RxPONDER so far, because I'm sure that we'll have more data and analysis probably next time in San Antonio next year. We could say that finally we have strong data for lymph node positive patients, saving a huge number of postmenopausal women of chemotherapy and all the toxic effect without offering any advantage. Clearly, there is an indication for chemotherapy in premenopausal lymph node positive patients with a recurrence score less than 25, but still there is a lot of room of using Oncotype DX in these patients because as we both agreed at the end of the day and when we discuss the results with our patients, Oncotype DX can help us have a more precise and balanced decision about systemic therapy, and particular about chemotherapy. Anything else you'd like to add for?
Thanks a lot for your introduction and of course for the summary, because you clearly got the point of the use of this genomic assay in patients candidate to chemotherapy in the adjuvant setting. Okay,
I would like to thank you, Giuseppe, for this discussion and help the ecancer discussions for their invitation. Thank you.